All right, so good evening, everyone, and thank you all for joining us for tonight's COVID-19 update webinar. My name's Beth, and I am joined tonight by our presenters, Associate Professor Charlotte Hespy, Associate Professor Penny Burns, Dr. Kerry Chan, and Dr. Lucas Dotoka. So before we get started, I would just like to make an acknowledgement of country. We recognise traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I'm now going to pass you over to Kerry to provide us with the latest update.
Thanks very much, Bethany. And I too would like to acknowledge the traditional custodians of the land on which we meet and pay my respects to elders past and present. So if I had been giving this presentation probably 2 days ago, I would have been saying that Australia was in a unique position of having or a few days ago, unique position of having no community transmission. Clearly, over recent days, we've had the transmission of a case in Queensland from an inpatient to a healthcare worker at the Princess Alexandra Hospital, and also potential transmission in the context of an hotel transmissions in quarantine. And in New South Wales, we've also had the situation of a security guard who was tested positive to COVID-19 with a UK variant strain, although the person who was purported to be the source was on a travel from Lebanon, and so reflecting the ubiquity of some of the variants of concern. In terms of update today, we have not identified any transmission within that person's household group or workplace at this point in time, but because we haven't got whilst we have genomic sequencing linking the case to a particular returned traveller, we don't, when we review all of the CCTV footage, we actually can't find how they connected there. And so because of that, we're just also wanting to rule out any additional person that may have mediated the transmission event. And that's a remote possibility, but so therefore we're taking a range of precautions around the Sofitel, Wentworth, where the person who was infectious was present from a period of about the 5th of March to the 9th of March. And then also taking down action where the person worked a shift at another quarantine facility. And there's a number of community exposures, and whilst we're managing those community exposures in the usual way, there's only one really close contact venue, the other a casual contact. So it is important, and we are expecting the community to come forward for testing. And I would urge you, if you're asked by any of your members of the community, should I get a COVID test, particularly if they've been to any of those geographic areas, those Coles and some of those very low risk venues, please, I would ask that you support your patients in getting a test. It is critical that we don't miss any unrecognised cases at this time as we really close down this transmission, and hopefully again move back to having no community transmission. It is an important setting to have whilst we have much of our daily lives turning back to similar in many ways, a little bit more constrained to the pre-Avalon, to our pre-COVID times. Also, it will afford us the best opportunity to roll out the vaccine without the constraints of having any transmission occurring at that time. So I think the desire is for us to go back to achieving no community transmission and then roll out the vaccine as quickly as we can. New South Wales has been focusing on rolling out the vaccine through a number of Pfizer hubs, and they've been particularly targeting our border workers and our quarantine workers and our healthcare workers in high priority groups. We've also been vaccinating aircrew. We're now commenced rollout of the 1B, and that will engage with a broader group of healthcare workers, as well as some other vulnerable groups such as correctional facilities. So I might pause there at Penny and Charlotte and allow the other speakers.
Thanks, Kerry. Look, Lucas, we'd like to have Lucas Detofa here today. And we wonder, Lucas, if you could just give us a little summary of the of your perspective on the GPRCs and the rollout from the national point of view.
Thank you. Videoing today from Untitled Country here in Canberra, Untitled Chapter. And I want to also acknowledge the owners of these land and pay my respects to their elders, both past and present. Always quite intimidating to speak after Dr. Chan, but yeah. So we are in a pretty exciting moment. Changing epidemiology aside, in terms of rapidly moving towards the commencement of phase 1B and the frank involvement of the primary care system in the rollout of the vaccines in Australia. So as you know very well, primary care, as always does in every immunisation program year after year, will play a key role in delivering the vaccine to everyone, particularly from the commencement of phase 1B, where general practices, Aboriginal Community Control Health Services and GP-led respiratory clinics, or GPRCs, will join the vaccination effort. The decision was made to bring GPs and GPRCs and naturals from phase 1B, particularly taking into consideration that as much as possible, it'd be really appropriate for the most vulnerable, older people and people with underlying conditions to access the vaccine from their own GP. There's a massive difference from this vaccine. There's a number of differences, but a key driver of this vaccination program compared to others is that we are in a global market for vaccine availability that we are trying to about to mitigate with the coming online of domestic production of a vaccine through the AstraZeneca manufacturing in Australia, but which means that unlike other programs like flu, we don't have millions of doses available at the beginning of the program that we can just distribute through the network, so that everyone has all they need for the season from the outset. We are receiving the vaccine in batches, initially internationally, and from next week onwards domestically, when CSL production of AstraZeneca vaccine is released from the week starting on the 22nd. And that means that we needed to make choices in facilitating that as many GPs as possible get the vaccine as quickly and as early as possible. And that's why, following the EOI process, we made a commitment that every eligible practice that submitted to the EOI would be rolled out within 4 weeks of the commencement of the program. Unfortunately, that means, of course, that the individual number of doses that go to every practice is probably more it's smaller than a lot of practices expected or assess that they require to go through their population. The commitment is that we wanted to make sure that we could provide a number that let you plan ahead and provided that equitable access across geography to as many general practices as possible, noting that as the model kicks in and we start to see the dynamics of supply and demand, as well as hopefully the domestic production ramps up or we receive more international dose allocation, we will be able to distribute more doses into the system so that general practices can be given the offer to ramping up their throughput, noting that we will never require practice to order or be expected to deliver more than comfortable doing, which is offering the option to order up to an amount, and that way we'll be able to expand. But we wanted to make sure that we could give general practices certainty of what that minimum number of doses that we can provide every week would be, so that they could have the option to plan ahead and order. And that's why the majority of practices in the rollout will be receiving 50 doses a week, which is 100 doses a fortnight, because it's delivered in boxes of 100 at minimum. But with the commitment that, as I said, as the model kicks in, we will be able to review and potentially increase those allocations, and later on increase the number of practices that are involved, so that other accredited practices that didn't put their hand up in the initial EOI and unaccredited practices, which many of them are very involved in immunization programs and very capable of delivering, so I would be able to join it at a later stage. So that the later we go in the program, the more doses we have, and the more widespread the program becomes, the more closely resembling the usual business in general practice will be. The commitment was made to sort of move away from a mass vac type of program. We didn't want to have GPs stopping what they're doing and becoming a different thing. And that's why going to as many as possible, so that people can access the vaccine from their GP it's making sure that we're working within the structure of general practice. Is also why, after a lot of the initial feedback, we've been very clear that the national booking system, or the so-called national booking system, the COVID vaccine information and booking service, I think is the latest name, will work with existing booking systems and existing practices, so that GPs don't have to change the way they engage with their population. If some GP doesn't have an online booking system and wants to opt in to a new one, they can use the one that the Commonwealth will offer, but otherwise the vast majority of practices, of ACHOs, of GPRCs will be using the systems that they already have tried and tested to engage with the population. It's just that it will be listed in the Health Service Finder so that people can find it. Last bit of my intro. As I said, exciting times, because week 1 of the primary care rollout commences on the 22nd. The practices that were invited to join in week 1 received their letter, their doses, and the confirmation of how to register and place their orders last week. The response was overwhelming. So over 1,200 GPs, GP respiratory clinics, and ACHOs nationally have already placed their order to receive their vaccines for week 1 commencement on the 22nd, and the orders will start to be confirmed, and practice will receive their schedule of delivery from tomorrow, so that they know over the coming days when they're going to get the vaccine ahead of their week 1 commencing on the 22nd. From tomorrow onwards, we'll issue codes so that the week 2 practices and those practices that chose not to participate in week 1 when they were invited, but they're still open to week 2, can do that registration and ordering process, so that staggering of the rollout continues, and by week 4, we can have that full complement of over 4,500 general practices, the GP respiratory clinics and Aboriginal community control health services across the nation providing the vaccine, and then look at what options for expansion are there when more doses become available. It's probably enough for the intro.
Lucas, while you're on there, there's a question that keeps coming up again and again, and it's around how will people know? How will people know they're eligible? How will GPs know? What is the system of inviting people to be vaccinated through these GP clinics?
So the system is, we're trying to make as much as possible a no wrong door type of policy. So we expect that, especially in 1B, we're talking about older people and people with underlying conditions. A lot of it will be proactive contact by their GPs, reaching out to their patients that they know are vulnerable, and that is completely encouraged. There's been a lot of concern from practices about the expectation that they see everyone, and it's true that this is a national rollout program, so we cannot explicitly in any way limit access to the vaccine in a practice to existing clients of the practice, but that doesn't mean that the practice needs to apportion or cohort appointments just for new clients, and they absolutely encourage, otherwise we wouldn't be going through primary care, to proactively reach out to their patients that know are eligible for the vaccine and booking them in. In addition to that, any other system that the practice has to normally reach their patients with an online appointment in their website or any other way, or how ACHOs or specialized practices that service particular populations might actually reach out and have drivers and bring people in, which is all allowed within the program. There will also be a central repository of all vaccination points managed through the National Health Service Directorate and Health Direct, that is already being fed that information as part of the registration process from their practices, so that anyone on the street, whether if their practice hasn't reached out or if their practice is not participating in the program, but still are eligible under 1B, will be able to log on, check the eligibility checker that they're eligible, and then be able to input their postcode and find a list of and a map of practices that are participating in the rollout. And then they will be able to contact each of those practices, whether they have an online booking system, it will direct to that practice's online booking system, or whether they're using the national one, or whether it's a phone call, they will be able to reach out and seek for an appointment. GP respiratory clinics, we expect, will play a significant role in servicing people who don't have a GP or whose GP is not participating, or people who are not eligible for Medicare but are still eligible to get a vaccine for free. So really, it's that approach that whatever's working already for GPs to engage, plus the centralized health service directorate, so that everyone can see at a glance where practices are available, and that will be started to be staggered from Wednesday, when their week 1 practices will go live in the Health Service Finder, and then as practices enroll, it will be updated, so there will be more and more vaccination points as the program continues.
Can I just also clarify there, Lucas, that for GPs running vaccine clinics, it's completely appropriate to request that patients who don't belong to them bring documentation or validity that they actually qualify for a 1B. And so that will be something that because I think GPs are quite concerned that people will be just rocking up and then push past patients that they see as being more vulnerable and really do need it, so that we can have conversations about, that you can't just say I qualify because I ticked the button and it said I was. You do actually need something to prove if you're going to another clinic about that. And so the GPs that own them will also have a requirement to be able to provide health summaries.
So absolutely. So two things on that. Ultimately, the practice retains complete control over their bookings. So as I said, you don't have to leave bookings open for walk-ins or for people who are not part of your regular clients. But some of the ones, especially the ones that have a large number of appointments, I think it will be, as part of normal operation, having some bookings online available. The other part is the communications campaign is going to change a little bit now that we're moving to 1B, and it will focus more on what the eligibility cohorts for the priority populations for 1B are, but also how to attest that. There's a vaccine provider information kit that is going out to all enrolled practices and other providers either tonight or first thing tomorrow. They'll have a number of information sheets to support conversations pre and post vaccination with payments or with patients. Will direct to links with updated information on the department's website, and we'll include a link to where the eligibility categories and the proof of attestation attached to all of them are, including, if all else fail, a declaration form that a patient can sign if they don't have, for whatever reason, the way to prove the eligibility in other ways, and they want to pre-fill that when they come to their practice. The eligibility checker will remind people to bring with them that evidence, which is as open as possible, so that it's not an impulse in the patient, a barrier for the patient, or an impulse on the practice. So essentially, depending on where we're talking about occupational eligibility, a letter of employment, an ID from that workplace. If we're talking about underlying conditions, of course, our summary, our GP referral, or my health record summary would be ideal, but also a script that is consistent with the condition that is listed, or an NDSS card for a person with diabetes. We're just trying to keep it as low impact as possible, but still giving you enough comfort that that person meets the eligibility requirement, and trying to minimize those opportunities of probably uncomfortable conversations at the practice point. So the eligibility checker will remind people that they need to bring in the information.
Thanks, Lucas. And I'll just also sort of roll that into that. There's a comment about the low numbers for most general practices only having 50, which obviously goes per week, and you've already talked about this, which is obviously nowhere near how many patients they know that they'll need to cover, versus the respiratory clinics will be being given much larger numbers. And as you noted, they will be being asked to cover for all the patients that are not having access to it through their own GPs, but also to patients who don't actually have a GP for whatever reason. But they'll also be able to provide it for those who don't have a Medicare card. And I think, again, there was a comment about, is there access for people who are vulnerable without a Medicare card? And I want to reiterate that that will definitely be through respiratory clinics. And I know that, and Kerry might want to talk to some of the clinics they're setting up in New South Wales Health, that they're also trying to make sure that homeless, vulnerable patients will be able to easily access their vaccinations through HIV clinics and through special clinics. And then finally, I'll bring that into, maybe Kerry, if you can talk about patients who have got adverse reactions or potential adverse reactions, could have anaphylaxis, that GPs might feel reluctant to vaccinate in a general practice setting, and where we might be able to get them safely looked after.
Thanks very much, Charlotte. So maybe I'll start at the beginning, which is we're very lucky that we've got the National Centre for Immunisation Research based in New South Wales, and we have, whilst it's funded nationally, New South Wales Health also contributes to that funding, and we have purchased some additional capacity for expert clinical advice. And so there is a mechanism by which GPs can discuss particular cases. I'm also aware that there's a number of decision supports that ATAGI is developing to support discussions of particular groups, those with autoimmune diseases, and others where there's more of a risk management discussion. So my first point to you, Charlotte, would be to support access, and we can circulate the contact details and arrangements. It's in the adverse events documents that we've circulated. And then obviously they do run some clinics there. And if there's a greater need for that, we can certainly look at that. They're also going to be working across our immunology sites with a few that have got a particular interest in anaphylaxis following immunisation. And again, looking at what services we will put in place to assess people that might have had anaphylaxis, both from an immunological anaphylaxis management perspective, but also to inform jointly the advice about the risk-benefit ratio of another vaccination and which vaccine would be used in that circumstance. In terms of the role, I mean, we're very pleased that we've got to this section where GPs are now engaged, and I just want to indicate that the major barrier to engagement has really been around volume of vaccine. And just to echo Lucas's comments, we're in an international competition for this product, and it's great that we've got these two are safe and effective vaccines with potential vaccines, additional vaccines coming online in 2021. But when the CSL production of the AstraZeneca comes online, that will give us a lot more predictability. And I just want to acknowledge the challenges that the Commonwealth's faced in regard to that. So once there is broad-based access through general practice, obviously with a focus initially on having to prioritise the clinics that the Commonwealth have set up due to the shortage of supply, the focus of the state will then turn on to those groups that are particularly not likely to be accessing general practice, be they homeless, very disadvantaged, or if we notice that the data is supporting that some groups are not accessing vaccination, we would potentially work in partnership with primary health networks and local health districts at looking at boutique solutions for that. We're also recognised that Aboriginal community controlled services are not distributed everywhere across the state, and that also some Aboriginal communities would choose other solutions. Some of that may be general practice, but some of it may be where the state or state services also set up clinics. And currently our local health districts are doing a bit of engagement with some of the Aboriginal communities to look at where there might be gaps and how we might partner, as I said, either in standalone clinics that we conduct or through partnership approaches with primary care.
Thanks so much, Kerry. There's quite a number of sort of other bits and bobs of questions coming through. Maybe, Penny, do you want to lead off and then I'll take off after there?
Look, I was just going to actually comment, going back to Lucas, actually. I just want to say that one of the things we're thinking of doing in our practice, we're getting 50 vaccines, was actually to look at what practices weren't getting the vaccine, and maybe doing a bit of partnership with some of those, and also linking in with them to see if some of their staff or some of their patients want to come and get vaccinated with us. So doing some sort of linkage within, facilitated by the PHN. One of the questions that was coming up, not in this chat, but otherwise, was on the eligibility tracker, the COVID vaccine eligibility tracker, Lucas, you can actually enter from the age of 16 if you've got immunocompromised conditions and qualify for the vaccine. Is that, my understanding is it should be only rolled out for the over 18. Did you just want to sort of clarify that, because that has been coming up as a question for a few GPs? Yeah,
thank you. That's a really good point. And there's going to be a number of updates to the eligibility checker to happen before Wednesday. From Wednesday is when we expect the Health Service Finder to be operational, and the eligibility checker will reply to that. And I saw a question in the chat about what website am I talking about. It will be accessible from health.gov.au and from Health Direct. So not dissimilar to the COVID symptom checker and COVID testing finder that already exists in Health Direct. But the question of...
Can I interrupt at that point? Is it going to provide information about those practices that will be coming online, or is it only going to say from this week? Because that's actually quite important. If a patient knows that their own practice is going to be coming online in 3 weeks' time, they won't get so panicky and are much more likely to be able to just wait for their own practice. Whereas if you're only going to roll it out as the practices get it, it's going to make it, I think, far more nerve-wracking for the practices who are in the first rollout week.
I note that, however, and this is the complicated balance, and I think being very transparent about some of our challenges helps, I think, to resolve them together. But we strongly encourage, like all practices know which week of the rollout they've been offered to commence. So every practice out of the 4,500 has known it for nearly 2 weeks now. So we strongly encourage practices to proactively tell their patients that is the situation. There's an enormous risk, and contrary to this position, Charlotte, we've had a lot of practices and parts of the college as well approaching us saying, please don't publish the list too early, because the practice is going to get inundated before they actually have any appointment to offer. So we're trying to make take this balance between giving as much information as we can without further putting even a higher burden on the practices to start to field calls before they even have the ability to set up the appointments, or they know exactly which day they're going to be starting. So at this stage, the plan is that on Wednesday, we will be showing the practices that are starting on week 1, and we'll have showing appointments for week 1, but we'll have a disclaimer saying that this will be changing regularly as more practices come in week by week. We're happy to review the approach, of course, but I would really, for those practices that are starting a bit later and are concerned that their patients might not realize that their practice is coming online, I would recommend that they do proactive communications with their patients, and their provider kit has a lot of examples of text messaging and emails that you can send, and that have all their approved information. But if you choose to use that, as opposed to having, which we could now publish the list of all the practices in the EOI, but there's a significant risk that practice will start getting calls even before they've worked out their appointment.
I think you're 100% right, Lucas, so I'm not going to dispute you. And I think what you've done is highlighted that the practices are allowed to let all their patients know exactly what the plans are, when they're coming online, and how they're going to communicate with them. And that will then probably assist them in managing anxious people as it gets rolled out.
Absolutely.
Yep.
I forgot the original question. Sorry.
No, it's okay. You've actually answered it. But one of the other things, there were a few things we were talking about before we came online that I want to make sure that we get through. And we were, and I think we were all talking about the storing in the needle and delivering the vaccine immediately once it's been drawn up. Are you able to comment on that sort of process, Lucas?
Yes, we've got a lot of questions on that. And what we've done is we've gone back to the Australian Technical Advisory Group on Immunisation and to the manufacturer, AstraZeneca, to be able to provide conclusive advice. We've had a lot of questions that the training says immediately, what does that mean? Can I draw all 10 of them just before the session and then administer them, kind of put them back in the fridge? The overall message is the vaccine needs to minimize movement and the time that is drawn up, the aseptic drawn up. Our processes might vary from practice to practice. So the general principle is to use up those syringes as quickly as possible. But we will be providing clear written advice to all practices on what does that mean in terms of whether can you pre-drawn them just at the beginning of the session and then use them within the hour, as opposed to having to do it immediately. And we understand that that's a key question for establishing the models of care and your format, how you actually structuring the vaccine through your clinic. So we're hoping that we're providing that advice in writing within the next couple of days. The general principle, as we said, we're trying to make things as sensible and as easy as possible. So we want to minimize the risk of the vaccine losing cold chain or being put back into storage after being pre-drawn, but we will provide the sort of expert and manufacturer specific advice on what do we mean by immediately, because we've had a lot of questions on that.
And I guess the next question actually is for Kerry. So there's been a number of questions coming up around, is the AstraZeneca safe after the reports coming out of Europe? Kerry, are you able to comment on that? And maybe that would also segue into the efficacy. So if GPs are going to get vaccinated, what sort of efficacy they've got and protection they've got before they get that second vaccination?
So look, both of the vaccines are very safe and effective, and the real-world experience that we're seeing from overseas supports that. Clearly, the TGA is a strong regulator and has daily hookups, as do our vaccine specialists and ATAGI, in monitoring the international evidence. The advice I've had is that the association with the blood clots is not something that we're minded to be concerned about. I think it just shows that we will be dealing with temporal associations between events and vaccination when we're progressively vaccinating 21 million people. And we need to take each of those events seriously and have a process. We need to report them to the TGA. We need to investigate them. We have got a good, a really robust surveillance system for adverse events. But at this point, I think we should have confidence in the safety and efficacy of the vaccines. In terms of the AstraZeneca vaccine, the AstraZeneca vaccine is a 2-dose, and ATAGI has indicated that 12 weeks should be the preferred is the preferred time to roll it out. And as time goes by, that may change as new studies come in terms of even lengthening that period, but it's three months. There are cases where there's exceptions to that, and again, they would be cases where potentially you could consider talking to the vaccine specialist, where you might want to, where someone's going to a very high risk setting, you might want to decrease the interval, but that would be an option to talk to one of our vaccine immunologists at the National Centre. In terms of the side effect profile, I just probably wanted to take this moment to say I received the AstraZeneca vaccine last week, and basically I had it at about 12 o'clock on a Wednesday. I certainly went to bed that night, didn't really have much pain in the arm, woke up the next morning, felt vaguely headachy, just vaguely off, did take some Nurofen that day. And but then that evening I did experience some fever, some joint muscle pains, certainly some fatigue. Went to bed, then woke up at 2 o'clock, had some more fluids, went back to sleep and felt much better in the morning. But I do want to say, I don't want to talk down the fact that a percentage of people from our data indicate that they will experience some of those side effects. And so we are giving guidance about not vaccinating your entire clinic staff on one day. Stagger it, and I think Charlotte had some great advice about thinking about doing that on a Friday evening, or at the end of shift. But it's certainly a consideration you have to have, and certainly we've provided advice to our health services about making sure that you stagger the vaccination so you don't have that issue. My understanding is that the first dose actually produces a pretty good response in terms of the AstraZeneca, and the purpose of the second dose is actually to sustain that response. Whereas in the Pfizer, what you're doing is giving a dose and you might get, say, 50% protection, and then that rises up, around 90% to after the second dose. Again, what we're protecting is severe illness. It's really hard sometimes to compare some of the studies because they're not using similar endpoints. But I think what's also important is the real life experience indicates that both the vaccines are safe and performing very well at protecting against that severe disease. There's much more to learn about its impact on transmission, and obviously we're worrying about variants of concern and the effect of the vaccine for those. So still a very much a learning phase. And Lucas, I don't know if you want to add anything that I've missed there.
Sorry, I'm muting myself. No, I think that was very comprehensive. Nothing to add from me. Sorry, just saying that we completely echo the advice on staggering for staff as well, and we will be providing advice with the next lot of comms that goes to the participating general practices as well, especially looking at the outcomes from our domestic reporting data. It's just safer if not all staff are vaccinated in one go, and we'll be providing that advice to general practice consistent with what Kerry went through.
And one of the other things is just so that the staff are not put off by that, probably being very quite overt, that this has probably got a bigger kick than perhaps, clearly I've had flu vaccines year in, year out, and this is certainly a different experience, and I know it's an N of 1, but some of our Vax Tracker data supports that, you know, a proportion of people will experience those sort of side effects. And as I said, they respond and recover quite quickly. But it is important that we're very open to patients, and you factor that into your, I suppose, advising them of what to look out for. And obviously, you've got the complexity that we've been largely vaccinating well people to date. You've obviously got people that are also got multiple health conditions, of which you'll have to then indicate when you're going to be worried about that, if the duration's longer or in certain clinical conditions. So that's going to be an added task for GPs to be giving that guidance to your patients, who are going to be much more complex than the ones to date that we've been vaccinating. Certainly we'll get into those more complex patients shortly.
Can I also sort of note in there about the adverse reactions, Kerry, that we're encouraging all GP practices to sign up with SmartVax as a really easy way to be able to gather in the information and not actually take time for it all to be reported, because it can happen then sort of pretty much automatically behind the scenes. But you will also be able to get really good information about what the adverse reaction rate is like. If you don't know who or what SmartVax is, it is a sort of an automated system where your patients will get sent SMS texts post-vaccine. They automatically get the notification the patient's had it through the same sort of system as your AI, you know, through your software, having it recorded into the system. And then the patient has a choice of responding or not to them. And I believe there's at least 2, if not 3 messages that are being sent out for the COVID vaccine. We've been using SmartVax in my practice for adverse reactions for vaccines now for about 4 years. I love it because I get a daily report and then a sort of an overall report of what's actually happening. And you can put up note, you know, basically just tell the patients they're going to get a message after the vaccine that they can just respond to very easily, which is a yes or a no. Have you had any adverse reactions? And then it gets dug into more deeply if it's a yes. But as I said, it happens behind the scenes. You don't have to do it. And it's fantastic because it actually means there's a much better database of every adverse reaction that can be captured.
Charlotte, just going on from that, there's been a few questions around what needs to be reported, and what needs to be reported is anything that's serious or anything that's unexpected, and that needs to go through the usual sort of either online reporting or phoning your public health unit. And then the other thing to know as well is if you've got questions around the vaccine or you're not sure about details, there is all those wonderful specialist immunisation support lines that you can phone. And for New South Wales, for example, it's open sort of 9 till 5, but then you can ring the Children's Hospital at Westmead and get put through at any time. So there's a lot of backup support there if you're having issues deciding whether a patient should be vaccinated or not. I can see a lot of questions coming up around NOACs and around pregnant patients and immunocompromised. I don't know if Kerry or Lucas, you wanted to comment on those?
No, I think we covered. I haven't read the question, sorry. The additional ones.
While we're on that one, sorry, you go, Kerry.
Pregnancy. Yeah, so I was just going to say on pregnancy, I think I'd go to the ATAGI website, and perhaps we can circulate the decision supporting tools. And at the moment, I think the advice is, given we've got no COVID, to defer to not vaccinate pregnant women at this time. Obviously, that might be a different situation if they're going into having to go into a setting of incredibly high risk. And so again, that would be something that I would be discussing with our vaccine specialists. For each of the other conditions that ATAGI is doing algorithms and decision support trees, but we'd be happy to make those available to GPs or the web links circulated so that people can be aware of what resources are there. And I'm not sure if the Commonwealth has a better website to go to.
Yeah, so all the target advice, including the pregnancy decision support tool, are in the vaccines hub of health.gov.au. It's also included in the onboarding pack, the links to that, and that all practices that are participating in the rollout received, and will also be linked in the vaccine provider kit that is going out either tonight or first thing tomorrow morning. But ultimately, there's a provider section in the in health.gov.au, and it has all those links.
Thanks. There's a few more questions about GPs accessing vaccination for themselves. Just to remind, all GPs are part of 1B. You do have a right to have a vaccination. If you're going to be a vaccine clinic, all the staff and the GPs obviously have access to those vaccines, and I would suggest, it's up to each clinic obviously how they're going to do it, but you should probably prioritise your staff first, and then actually sort of have some idea about how you're going to prioritise your patients. And if you aren't a vaccine clinic, then you will be able to access it through the respiratory clinics or a neighbouring practice, like Penny was talking about, assisting neighbouring practices. So maybe find out where the nearby GPs are and or respiratory clinics so that you know how to access it. But you are a priority under 1B.
To confirm, all healthcare workers, and that includes their clerical and support staff in your practices, includes students on placement, and of course any health practitioner that weren't otherwise eligible in 1A have now become eligible in 1B. And of course, if you were eligible in 1A for whatever reason and didn't get a shot, as many people in the health workforce did in the few weeks that we've had under 1A, you can still access it through any of the 1B facilities. Is that the eligibility is not a sort of exclusive thing that now the 1B starts, 1A stop being eligible, because we've received questions about that.
Yeah, thanks for that, Lucas. Sorry, I was just going to reiterate, all students do have a right to access that under 1B. So please encourage that, particularly if you are a practice doing it, don't turn people away who are healthcare workers in any way. They do qualify. And from my take on it, I think they should be prioritised because they are in the front firing line, really. It's a bit like, as we've been seeing, the people who've been infected in the last few days, as Kerry's noted, have been people who are in that front field line of the work as much as anything now. And patients without Medicare, send them to the respiratory clinics, because that is a mechanism for them to be able to access it without Medicare, and there is no charge. And Lucas, do you want to talk about the ARR very quickly for patients not on Medicare? There will be a system of it being uploaded into the register for them.
Yeah, absolutely. So AIR is not Medicare dependent. Of course, a Medicare card makes it quicker and easier to link, but an individual health identifier can be generated with date of birth and name. So people who don't have a record on the air, people who don't have Medicare card, and people who might still not have an IHI, that record can be created on the spot just by entering the details as part of the upload, so that every single vaccination administered in Australia, whether it's in a Medicare eligible or not, and someone who's eligible to Medicare or not, and whether someone has the Medicare card with them or not, can be entered into it's not a Medicare dependent process, and that includes people on gold cards for veteran affairs or other arrangements.
So that would actually be similar to the swabbing then, Lucas?
In what context?
In terms of testing and not requiring a Medicare card to be able to access the GPRCs for testing.
Oh yeah, absolutely. So that's partly why we're using the GPRC as a platform, because they are directly contracted by the Commonwealth. They can invoice us in a Medicare independent process. So yeah, the same eligibility essentially, and that we've opened the eligibility to remove some of the complexity of certain visas versus others. Anyone in Australia who meets eligibility by age or any other requirement is eligible to get a vaccine for free in Australia.
Thanks, Lucas. And just to reiterate, all healthcare workers, all other healthcare workers, in other words, anyone who works in health and their staff who haven't qualified in 1A do qualify in 1B. So that is everybody. So we don't need to sort of we can be pedants in any way, but anyone who is a healthcare worker, breastfeeding mothers can get vaccinated. It's just the pregnancy that has limitations at this point in time. Kerry, do you want to talk on that one at all, or are you happy to?
Look, I think we just got the decision support. As I said, the only exception I'd be contacting for expert advice is if someone's going to be travelling overseas because they have to for emergencies, and others where it becomes a more nuanced discussion about risk benefit. But ATAGI's made it, provided that advice and decision support tools. And if people have got queries, again, I'd refer you to the National Centre experts.
I guess the other question too is around, there's a question here around mandatory vaccination. One person's saying that staff have been informed that their hours will be reduced if they don't have the COVID vaccine. Kerry, did you want to comment on that?
So the position that we've articulated, and that's been quite public, is the fact that, you know, Australians generally embrace immunisation. This is a new vaccine. You know, personally, I don't want to overlay it with a mandatory status at the beginning. There's enough people, there's a shortage of vaccine and we've got enough people to vaccinate. So no, we haven't been mandating it. Will that always be the case? And I think I would say we treat this vaccine like we do every other vaccine. We make a sort of assessment for our healthcare workers. People may be familiar that New South Wales Health has a policy framework where certain vaccines are required for working in certain areas. You can imagine in a NICU and a neonatal intensive care with little babies, pertussis vaccine is a requirement. So we tailor it to the setting, and we'll go through the same process with COVID. And usually there is a requirement that if you're not vaccinated on medical grounds, then you can still work, but you have to take additional precautions. Or in some circumstances be redeployed depending that risk assessment. So I think we'll follow the same framework for COVID as we go ahead, but obviously the situations change. But I'm sort of optimistic that the majority of people, as have taken up other vaccines, will take up COVID vaccine.
Maybe some other issues might be good to go through some of the processes. There's been a couple of questions about, you know, the how-tos, I suppose, in terms of how long is immediately. Lucas, I don't know. Do you think we adequately addressed the immediately
for the pre-draw? No, I did say I wasn't addressing it adequately, and we will provide the advice directly from the manufacturer and ATAGI in writing in the next couple of days, because immediately is not enough. The general principle is as quickly as possible, but we need to provide clear advice so that people know whether they can pre-draw 10 of them at the beginning of the session and use them up within the hour, or the way that we're talking about going one by one. So we will be providing that clarification of what we mean by immediately in writing in the next couple of days. I did not address it. No, I did not address it adequately.
Yeah. Sorry, I just wanted to clarify that in the meantime, I think everybody just needs to plan for having a system where you draw up a vial and be pragmatic about it. The biggest issue is not shaking the vaccine. It does not want to be shaken, and we're used to shaking vaccines. So that's your biggest risk, I think, is that GP vaccinators need to remember, do not shake vaccine.
Can I ask, I ask this every time, I think, is there any talk about when the flu vaccine will be coming out? Partly because it's going to impact on practices that are focusing on the COVID vaccine delivery.
So the vaccine is going to be coming out soon. It's going to be distributed in, I think we've got sufficient stocks to start distribution towards the end of March, with the flu season flu vaccination commencing on the 1st. What we're making it very clear is that please get the COVID vaccine into your patient's arms before the flu vaccine, if you know that you've got them for your patients. So prioritisation of COVID over flu, because as you're aware, there's a 2-week gap between the vaccines. We currently do not have any flu activity, and we had a very flu-free year last year. and we would anticipate that that will continue. So we have got time to progressively roll out the flu vaccine. We will be doing it in a pre-allocated way. So we've tried many times to get our allocation and logistics done well. So, but this time what we're doing is, based on your previous usage last time, we're actually giving you a pre-allocated amount. And I think you've got to confirm that amount. So that should be the process. So perhaps if you could go back and check with your practices that you've been pre-allocated and that you've confirmed or accepted that pre-allocation, then the vaccine will be coming out to you. And as I said, please continue to flu vaccine, but the messaging strongly to patients as well will be to preference COVID. If you've got an opportunity of getting access to COVID, preference that over getting the flu.
Can I be slightly controversial there, Kerry? Because I'm actually suggesting that for most GPs, their access to COVID is going to be slow, and they may well have their flu vaccines well ahead of actually accessing the bulk of their COVID vaccines. If I think of, I'll use my practice as an example, where week 3, which is going to be the week of the 2nd of April, when we're going to get 50 doses a week, where I'm expecting the flu vaccine to be coming out at the same time, and we know that we're going to be giving X amount, and it's only going to be 2 weeks after the flu vax is given before we can give them COVID. So I actually think it's not a bad opportunity to upskill them, give them a good sort of information around what we're going to be doing with the with COVID, as well as doing a health check, which we normally do with our flu vaccine, so that then the COVID vaccine can be scheduled in 2 weeks later, and then the 12 weeks after that, with far less time really being needed to upskill them and sort of increase their information around what they need to be wary about with the COVID vaccine, knowing that the billing for COVID is very tight. You can only really, it's a 5-minute payment time. So there's not going to be really any chat time if people want information, whereas we can do that with the flu vaccine.
Look, I think it's about you just knowing the amount of vaccine you've got, where your patients are. But as I said, we'll be supporting. There's no rush for flu vaccine, just to give you that flexibility if you've got people that are anxious. And we will just be messaging that there has to be a 2-week gap at this point in time, which is consistent with the ATAGI advice. So I think locally make that decision in terms of your local circumstances, and I'll take that in mind, Charlotte, of making sure that we're, saying where it's available, please take it up. But if it's a converse, grab the COVID vaccine when it's offered to you. Yeah.
And I think and I don't think the positions are incompatible. I think it's again, as you said before, it's a pragmatic and sensible approach. We don't want COVID doses sitting on a shelf being unused, but as you said, with the allocation of 50 or 100 a fortnight or 50 a week, if you also have a flu on the side, you can manage both allocations. But I think fridge space is not going to be an issue with the frequent deliveries and relatively small numbers. So I think the general principle that on availability of both and vulnerable cohort to prioritize COVID, but of course, if you have plenty of flu supply and you're not coming up until later for the COVID one, of course, then don't hold back your flu vaccination program. I think ultimately GPs are very pragmatic on this thing.
Yeah, look, we're going to be really busy. We've got three lots of vaccines to give to the most vulnerable, and then we've also got all the COVID for everybody who doesn't. Well, they may be wanting flu at the same, as well, but we've got a lot of vaccines to be giving out, so we just need to get it happening, I think, and making sure the systems are safe. We also have the next there's also for 70s and overs, a lot of them are going to need the Prevnar because of the change in the guidelines around the pneumococcal vaccination as well. So it's sort of, it's a busy time for GPs, but a great opportunity to do good increases in health literacy and preventive care, sort of those opportunities. In terms of written consents, I'll just sort of, basically, you do not have to do a written consent, But certainly if you have a system that aids and abets it, then it's probably a good idea, because you certainly want to make sure that everybody has been adequately consented. And if you've got a written consent, you can, it's a little bit more well documented around it, given all of the conversation about people's concerns about the vaccine. Happy to take.
Although Charlotte, I would suggest that you could treat it the same as influenza, and that it actually isn't necessary. I don't know.
Look, I think so. I mean, my thing is make sure you've given them the information, and we're going to make sure everybody gets emailed it. There's a system you can do it, and as long as you've sort of definitely made sure you've got a form that you tick off to say that they know and aware, then I agree. I don't think you have to have a signed consent form uploaded into the file. It's just making sure that it is adequately informed and demonstrated that you've checked that they understand the process.
Look, I'd also highlight that we've got some videos online with some narration. I think Christine McCartney's done a few videos and things, so it might be useful also that the college circulates those things that might be useful. You could be also playing those things in loops, or making them available in waiting rooms, or sending them out to your, like a little podcast to the client. So I think that we understand the consenting process. Some people engage well with the written word, others engage with, visuals. So I think it is that point, making sure they've had the opportunity, read and understood, or understood the content, and had the opportunity to ask questions. Sorry, Lucas.
No, that's completely consistent. And I just wanted to clarify, subscribing everything that the three of you have said. We have provided, and it's linked in the onboarding pack and the provider pack, a sort of example template of informed consent form that has been developed with ATAGI. As we've said throughout this answer, it's a tool to aid those discussions and those conversations, and optional for use or adapt for a practice. Is in no way requirement of the program that you obtain written consent or that you do it with that form.
Thanks, Lucas. A final thing, just about the 80-20 Medicare rule. Can I confirm the 80-20 Medicare rule does not apply to your COVID vaccination Medicare item number? However, it will apply if you are seeing patients for something else on the same day. The 80-20 rule will still apply for all other Medicare item numbers applied to that same patient. So, and this is basically to discourage people trying to rort the system really, and putting through a mass of other Medicare item numbers. So Medicare item 80-20 applies as normal to everything else, but not to your ability to run numbers through a vaccination clinic.
That is correct. For once, I'm not going to give a long convoluted answer. That is just correct.
Thanks. And telehealth, yes, it's been confirmed it will be continue until the end of July, but we still don't have any information about following that.
Sorry, June 30.
And
June 30th, sorry, that's till July. Sorry, that was me. So the 1st of July, we have to get a new approval for.
And Charlotte, Kerry and Lucas, look, thank you very much for tonight. I think we've actually come up close to time. I thought we might give Bethany a couple of minutes to just round things up.
Thank you, Penny. Well, I will keep it short and sweet, actually, and give everyone a little bit of an early mark. But I just wanted to pop on and say a big thank you again to our presenters, Kerry, Charlotte, Penny, and Lucas. Always a pleasure to have you on and providing us with such great information. Thank you to everyone online. Thank you for all of the questions, and the next webinar will be held in April. I'll send out some information for that in the next week or so with a registration link. So thank you again, and have a great night, everyone.
Good night.